1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's,
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
Imagine a nurse, right, just absolutely sprinting down the hall to a postpartum room.
Yeah, that terrifying moment.
Exactly. A mother is hemorrhaging. I mean, every single second counts here, and the amount of blood loss is just, it's becoming catastrophic.
It's the ultimate obstetric emergency.
Right. But before that nurse can even push the life-saving medication into the patient's IV, they have to stop. They have to put on a biological safety gown and, like, snap on double chemotherapy gloves.
Which just feels completely counterintuitive in an emergency.
It really does. Today, we're doing a deep dive into a drug so incredibly potent that it saves lives in literally a matter of seconds, yet clinically, it's handled like toxic waste.
It is, hands down, one of the most fascinating paradoxes in pharmacology. We are talking about methylergonovine.
Also commonly known as Methergine, right?
Exactly. And our goal for you today isn't just to, memorize a standard drug card or run through some sterile, boring list of facts.
No, we're translating this incredibly dense clinical profile into a functional 80-20 mastery guide.
Right, because if you're a nursing student listening to this, or even a clinician brushing up on your obstetric pharmacology, we know studying these meds can feel like drinking from a fire hose.
Oh, totally. You're expected to just magically know all the mechanisms, the half-lives, the obscure interactions.
But out on the floor, or when you're sitting for a major licensee exam, pure rote memorization just completely falls apart.
It does. You really need to understand the physiological cascade. You have to know the actual why behind what's happening.
That is the absolute key. When you understand why a specific route of administration is so dangerous, or why this particular medication requires protective gear you usually only see on an oncology ward,
then the nursing implications just become intuitive.
Exactly. You stop memorizing arbitrary rules and you start anticipating the physiological outcomes for your patient.
Okay, so let's just jump right into the core of what this drug is and why it's used in the first place.
Let's do it.
Chemically, our sources say methylergonovine is a semisynthetic ergot alkaloid derivative, which, that sounds like something a medieval apothecary would brew up in a cauldron.
Well, you're not entirely wrong. The ergot alkaloids actually do have this wild ancient history. They originate from a fungus that grows on rye.
Wait, really? A rye fungus?
Yeah. But obviously in modern clinical practice, this specific semisynthetic derivative is incredibly precise.
Right. It's not just moldy bread.
Definitely not. Its primary therapeutic goal, what it is fundamentally designed to accomplish in the body, is to increase the strength, the duration, and the frequency of uterine contractions.
And by doing that, it mechanically stops postpartum bleeding.
Precisely.
So let's paint a picture of what's actually happening in the body when this drug is indicated.
Good idea.
The primary indication is the management of uterine atony, subinvolution of the uterus, and postpartum hemorrhage.
And this typically happens after the delivery of the placenta, right?
Yeah, or sometimes in the second stage of labor, like right after the delivery of the anterior shoulder. But let's really focus on uterine atony because that is the massive emergency.
Atony literally just means a lack of muscle tone.
No tone at all.
Right. And to understand the gravity of this, you really have to look at the anatomy of the pregnant uterus.
It's massive, right?
Huge. At full term, blood is pumping through the uterine vasculature at just an astonishing rate. We're talking upwards of 700 milliliters per minute.
700 milliliters a minute. That's insane.
It is. The placenta is attached to the uterine wall, and it's fed by these massive spiral arteries.
And when the baby is born and that placenta detaches, it basically leaves behind a giant open wound on the inside of the uterus?
That's exactly what it is. Those spiral arteries are essentially torn open.
So they're just bleeding freely into the uterine cavity?
Yes. And in a normal, healthy physiological response, the myometrium, which is the thick muscle layer of the uterus, it contracts powerfully.
It clamps down.
Right. The muscle fibers actually physically weave around those blood vessels. So when the muscle clamps down, it acts like thousands of tiny living tourniquets.
Oh, wow. I love that visual. Tiny living tourniquets.
It squeezes the blood vessels shut and mechanically stops the hemorrhage.
So think of it like this, right? The postpartum uterus in atony is basically an overstretched, exhausted, leaking balloon.
That's a great analogy.
It's totally lost its elasticity. It just can't clamp down on its own. So this drug, methylergonovine, it acts as a chemical shrink wrap.
Chemical shrink wrap, exactly.
It hits the system and forces that flaccid balloon to instantly, violently squeeze shut and just hold that position.
And that sustained squeeze is the critical part. The clinical data we pulled from the source specifically describes its action as inducing a rapid and sustained tetanic uterotonic effect.
Wait, tetanic? Like tetanus?
Yes, tetanic is the operative word there. It is not a rhythmic contraction.
Right, it's not like labor where it squeezes and relaxes, squeezes and relaxes.
Exactly. It squeezes and holds. It just locks down. And that shortens the third stage of labor and mechanically stops the patient from just bleeding to death.
What's really interesting here is that the clinical profile notes methylergonovine is preferred over other ergot alkaloids for this exact purpose.
It is the gold standard for this specific mechanism.
But if ergot derivatives are just generally known to cause contractions, why is this specific semisynthetic version the golden child of the labor and delivery ward?
Well, I mean, it really comes down to this delicate balance between efficacy and toxicity.
Okay, how so?
Ergot alkaloids, as a broader class, are notoriously unpredictable. They can be highly, highly toxic to the human body.
Right.
But the pharmacological data shows that methylergonovine, when it's prescribed and administered appropriately, rarely causes that severe ergot-related toxicity you see with the older derivatives.
So it delivers that massive life-saving shrink wrap effect on the uterus, but it keeps the systemic toxicity as relatively minimized.
Exactly. Again, provided it's used correctly by the nurse.
And that is a huge foundational concept for you as a student. If you're looking at a clinical scenario on an exam and you see methylergonovine, your immediate mental reflex needs to be...
We are stopping a massive postpartum hemorrhage by throwing a chemical shrink wrap over a flaccid uterus.
Boom. Exactly. But to understand how it actually pulls off this mechanical feat, we have to kind of look under the hood at the receptor level.
And this is where the pharmacology gets incredibly complex, but also really, really revealing.
Yeah, looking at the mechanism of action in the source material, it's almost dizzying.
It's messy. Ergot alkaloids are chemically messy. They do not just fit neatly into one single type of receptor like a perfect key in a lock.
They kind of interact with the whole soup of receptors across the body.
They really do. It acts directly on the smooth muscle of the uterus, but it's doing it through multiple overlapping pathways.
So the profile says it's a potent antagonist of serotonin receptors in certain smooth muscles. But wait, an antagonist blocks a receptor.
Right.
If it's blocking serotonin, how on earth is it causing a contraction?
That's where the nuance of receptor pharmacology comes in.
Yeah.
It blocks serotonin in some tissues, yes. But in human umbilical and placental blood vessels, it acts as a partial agonist of serotonin receptors.
A partial agonist. Okay, meaning it binds to the receptor and stimulates it, but just not as strongly as the body's natural serotonin would?
Precisely. It's a partial stimulation. And it doesn't stop there.
Of course not.
It is also interacting with dopamine receptors in the central nervous system.
Which acts as both a partial agonist and antagonist, depending on the specific receptor subtype. Right?
Exactly. It's everywhere. But for our purposes, for you, the nurse standing at the bedside, the most vital receptor interaction, the one that drives almost all of your nursing implications and your monitoring.
Is its effect on the alpha-adrenergic receptors?
Yes, the alpha-adrenergic receptors.
The clinical profile explicitly states that methylergonovine is a partial agonist of alpha-adrenergic receptors in blood vessels. This is the big one.
It is the absolute core of the drug's danger profile. You have to understand this part.
So let's break that down for the listener.
When you agonize or stimulate an alpha-adrenergic receptor in a blood vessel, that vessel constricts. It narrows.
It clamps down hard.
Yes. This systemic vasoconstriction is what helps clamp down the bleeding in the uterus, but it is also what causes the patient's blood pressure to just absolutely spike.
Because you're suddenly forcing the exact same volume of blood through a much narrower set of pipes.
Exactly, which means the heart has to pump exponentially harder to push blood through all that new resistance.
Wow. And beyond just the peripheral blood vessels, the profile explicitly warns about the normal response of the coronary arteries to ergot alkaloids.
And what do? They spasm.
They literally spasm. You get coronary vasospasm, which physically decreases the luminal diameter, the opening of the arteries feeding the heart itself.
You're choking off the blood supply to the heart muscle.
We are going to dive deep into what that coronary vasospasm looks like clinically when we get to the side effects, because frankly, it's terrifying.
It really is.
But first, let's trace how the body processes this drug, because the pharmacokinetics directly dictate how you administer it.
The metabolic life cycle of methylergonovine is fast. It has a really short elimination half-life.
Typically between half an hour to 3.5 hours, right?
Yeah. It clears the plasma rapidly, and it's extensively metabolized by the liver. It gets in, it forces the contraction, and it gets cleared out.
But there is a really fascinating physiological quirk in the absorption data here.
The oral route, right?
Yeah. If you give this drug orally, the bioavailability is roughly 60%. But the rate at which it absorbs completely changes depending on who you give it to.
This is such a great example of clinical context.
The clinical trials show that in healthy adult males, the time it takes to reach maximum concentration, the Tmax, is just 30 minutes.
30 minutes for a guy.
Right. But in females, during the puerperium, meaning the immediate postpartum period, that Tmax stretches out to 3 full hours.
3 hours versus 30 minutes. That difference is a perfect illustration of how a patient's current physical state alters pharmacokinetics.
It's wild. Why does that happen?
Well, think about a woman who has literally just delivered a baby. Her body has undergone massive trauma.
Yeah, extreme fluid shifts, immense physical exertion.
Huge hormonal swings.
Yeah.
In that acute postpartum state, the body's sympathetic nervous system is still heavily engaged. Blood flow is redirected away from the gut to prioritize essential organs.
So gastric motility basically just slows to a crawl.
Her stomach and intestines are basically hitting the pause button. They're not prioritizing the digestion and absorption of an oral tablet right now.
So the drug just sits there in her stomach, slowly dissolving, taking 6 times as long to absorb into the bloodstream compared to a non-postpartum patient.
Exactly. Which means if you have a patient actively bleeding out on the bed from uterine atony, handing her a pill that's going to take 3 hours to peak is, well, it's worse than useless.
You're losing precious, precious time.
It directly dictates your clinical decision-making. You reserve the oral route for stable management, not for an acute rescue.
That makes total sense. Now, I do want to highlight one random, slightly bizarre detail from the pharmacokinetic data we read.
Oh, the canine milk thing.
Yes. The researchers specifically noted that while human maternal breast milk concentrations of the drug are clinically non-significant, it exhibits, quote, good penetration into the breast milk in canines.
I mean, it really pulls back the curtain on how exhaustive toxicological and pharmacokinetic testing actually is.
They tested on dogs.
They rely on diverse animal models to map out exactly where a compound travels in mammalian tissue.
Well, good to know for the veterinary listeners out there.
Right. But even though the human milk concentration is technically low, we'll see later why lactation is still a major absolute contraindication for human mothers.
Right, we'll get to that. But before we move off the physical properties of the drug, there is a massive nursing safety implication regarding its environmental stability.
Storage is critical with this drug.
The profile is incredibly strict about this. It states that all formulations are highly unstable if exposed to heat, light, and moisture prior to use.
This is a direct patient safety issue that falls squarely on the nurse's shoulders.
Because when you pull a vial from the medication room, you are literally the last line of defense.
Exactly.
Yeah.
If that vial was accidentally left out on a counter under fluorescent lights, or, exposed to high temperatures in transit, the active compound degrades rapidly.
And pushing a degraded, ineffective dose of methylergonovine into a hemorrhaging patient is a catastrophic failure.
You might stand there watching the clock, waiting for a contraction that is never going to come.
While the patient just continues to lose blood.
That is exactly why the administration guidelines explicitly mandate a visual inspection by the nurse.
The parenteral product, the injectable liquid, it must be clear and colorless.
Clear and colorless. If you hold that vial to the light, and it has even a slight yellow tint, or it looks cloudy, or you see tiny particulates floating in it, you discard it immediately.
That's a classic clinical scenario right there. You pull the med, it's slightly discolored, but the patient is actively bleeding. Do you give it anyway because it's an emergency?
Absolutely not.
Never. You throw it away and you sprint to grab a pristine vial because a degraded drug won't stop the hemorrhage anyway.
It's those split-second decisions that really define clinical excellence.
Yeah. And those decisions become even more critical when we look at exactly how we are putting this drug into the patient's body.
Which brings us to the administration routes.
Right. Because this drug degrades easily and acts powerfully on those alpha-adrenergic receptors we talked about, the route you choose is literally a matter of life and death.
So let's break down the 3 primary routes from the source: oral, intramuscular, and intravenous.
Okay, we already established that oral administration is slow, taking up to 3 hours to peak in a postpartum patient.
So the typical adult dosage of 0.2 milligrams, taken orally 3 to 4 times daily, is strictly for non-emergent management.
Right, you'd use the oral tablets to manage something like subinvolution, where the uterus is just sluggishly returning to its normal size over days, or to control mild, ongoing postpartum bleeding.
But there is a hard cap on this.
Yeah, the clinical profile advises patients not to exceed the recommended dosage or duration, which is a maximum of 7 days. Why only a week?
Cumulative toxicity. Remember the primary mechanism. It's an alpha-adrenergic agonist causing systemic vasoconstriction.
Right, clamping the vessels.
If a patient takes this drug continuously for weeks, that prolonged constriction of the blood vessels can actually lead to severe peripheral ischemia.
You are slowly starving the extremities of robust blood flow.
Exactly. 7 days is the strict limit to prevent that cumulative ergot toxicity from building up.
Okay, so that's oral. Let's escalate to the parenteral routes, starting with intramuscular or IM.
The standard dose here is a single 0.2 milligram injection.
Usually given right after the delivery of the anterior shoulder or the placenta, right?
Yeah. And the onset of action here is aggressive. We're talking 2 to 5 minutes.
And you inject it deeply into a large muscle mass to ensure rapid systemic absorption.
And you can repeat this dose every 2 to 4 hours as needed. But the clinical data provides a really critical warning here for nurses.
What is it?
If the patient doesn't respond to the first dose, it is highly unlikely that additional doses will be of any benefit.
Oh, wow. That's a crucial piece of clinical logic.
It is. If you give the IM injection, wait 5 minutes, and the uterus is still flaccid and bleeding, giving a second dose isn't the answer.
Because you've already saturated the receptors, right?
Exactly. The chemical trigger has already been pulled.
So if the uterine muscle itself is incapable of responding, maybe the tissue is too exhausted or there's a structural issue like retained placental fragments inside, flooding the body with more methylergonovine won't force a contraction.
No, it won't. It will, however, dangerously increase the systemic vasoconstriction.
You're just adding side effects without any therapeutic benefit.
Precisely. You need to pivot immediately to other interventions, like different uterotonic agents or a balloon tamponade or even surgical options.
Now, the guidelines also state clearly that intramuscular is the preferred parenteral route.
Yes, highly preferred.
It's preferred because it carries a lower incidence of sudden, severe side effects. But preferred over what? Over the intravenous route.
And the 5E route is where the danger profile of this drug just absolutely skyrockets.
The dosage for 5E is the same, 0.2 milligrams. The onset is immediate. But the clinical profile practically screens at the reader to avoid this route.
It does. It explicitly states guidelines do not recommend intravenous administration.
And we have to ask why. Why is a standard route of administration for so many emergency drugs so heavily restricted here?
The profile gives the terrifying answer. It says, quote, because of the possibility of inducing sudden hypertensive and cerebrovascular accidents.
A cerebrovascular accident, meaning a stroke.
Yes.
Pushing this drug via IV can literally cause a stroke on the delivery table.
It's incredibly dangerous. Let's walk through the physiology of why that happens.
Please.
When you give a drug intramuscularly, it absorbs into the capillaries over a few minutes. It gently ramps up the concentration in the blood.
Right, a slow curve.
But when you push it intravenously, you are delivering a concentrated bolus of a potent alpha-adrenergic agonist directly into the venous return.
It goes straight to the heart.
It hits the right side of the heart, passes through the lungs, enters the left ventricle, and is blasted out of the aorta in one massive wave.
And as that concentrated wave hits the arterial system, including the carotid arteries feeding the brain, every single alpha receptor it touches is instantly stimulated.
Instant, violent vasoconstriction. The vascular resistance spikes vertically in a matter of seconds.
And the blood pressure just follows suit, creating a massive hypertensive crisis.
In the brain, those violently spasming blood vessels can either restrict blood flow so severely that it causes an ischemic stroke, Or
the pressure spike can cause a vessel to physically rupture, resulting in a hemorrhagic stroke. But here is where the clinical reality gets really, really complicated.
it always does.
If the IV route is so incredibly dangerous that it can induce a stroke, why is it even an option? Why is the FDA or the clinical profile even list an IV dosage?
Because it's the ultimate desperate measure. The guidelines state you only use the IV route if it is essential as a life-saving measure.
Like when?
Consider a patient who has already lost a massive volume of blood. They are in hypovolemic shock.
Okay.
When the body is in severe shock, it shunts all blood flow away from the peripheral muscles to protect the core organs.
So if you give an IM injection into the thigh or the glute of a patient in profound shock, the drug just sits there in the muscle tissue.
Exactly. There's no blood flow there to absorb it and carry it to the uterus.
Ah, so the IM route becomes functionally useless.
Yes. In that specific, terrifying scenario where the patient is literally seconds away from exsanguination, you might be forced to go directly into the vein to get the drug to the uterus.
But even in that life or death moment, you cannot just slam the drug into the IV port.
Never. The guidelines mandate a very specific administration technique.
What is it?
Give 5E slowly over a period of no less than 60 seconds with careful monitoring of blood pressure, heart rate, and uterine response.
No less than 60 seconds.
Yes.
You are standing there with a patient actively bleeding out, and you have to force yourself to slowly, meticulously push that plunger over a full minute.
It's agonizing to think about.
It really is, but you're doing it to give the cardiovascular system a fighting chance to accommodate the drug.
Exactly. You're trying to spread that wave of vasoconstriction out over multiple cardiac cycles instead of hitting the receptors all at once.
And there's one more absolute non-negotiable contraindication regarding injections from the source.
The arterial warning.
Yeah. The profile warns that periarterial or intra-arterial injection must be strictly avoided.
Meaning you do not inject this into an artery or even into the tissue immediately surrounding an artery.
What happens if you do?
If you push a potent, long-acting vasoconstrictor directly into an arterial feed, you will completely clamp off the blood supply to whatever tissue bed that artery supports.
It just shuts it down.
It causes instantaneous ischemia, and if it's not rapidly reversed, necrosis and tissue death.
The margin for error is just razor thin with this drug.
It really is.
So we've established that pushing this drug too fast via IV can cause a stroke. That alone should command ultimate respect for this medication.
But it doesn't stop there.
No, the cascade of adverse reactions goes so much deeper. The cardiovascular and neurological side effects are intense.
They are, and if you understand the systemic vasoconstriction we just discussed, every single one of these side effects makes logical sense.
Okay, let's start with what the profile classifies as the most common adverse reactions.
Sure.
We have headache occurring in roughly 10% of patients, hypertension, also around 10%, nausea, vomiting, and abdominal pain in up to 10%. We also see early occurrences of hallucinations, dyspnea or shortness of breath, chest pain, palpitations, and peripheral vasoconstriction.
Look at the underlying theme there. The headache is a direct result of cerebral vessel constriction.
The hypertension is the systemic clamping of the vascular bed.
Exactly. The palpitations and chest pain occur because the heart is suddenly forced to pump against a massive wall of resistance, which increases myocardial oxygen demand.
Even the abdominal pain and nausea can be linked to decreased splanchnic blood flow as vessels in the gut constrict.
It all ties back to the alpha receptors.
But then, the profile lists the severe, rare adverse reactions. The incidence is listed as not known, but they are thoroughly documented and they are devastating.
Let's hear them.
Rapid onset of anaphylactoid reactions, early onset of uterine rupture, rapid onset of bradycardia, early onset of ventricular tachycardia, ventricular fibrillation, and AV block.
Get a heavy list.
It keeps going. Stroke, which we covered, delayed onset of myocardial infarction, early onset of coronary vasospasm, and delayed onset of water intoxication and seizures.
Let's break down the cardiac events first, because seeing VTach, VFib, AV block, and myocardial infarction on a side effect profile is it's really alarming.
How does an alpha-agonist cause the heart's electrical system to degenerate into ventricular fibrillation?
It traces directly back to the coronary vasospasm.
Right. The arteries on the heart.
Yeah, the coronary arteries wrap around the outside of the heart, supplying the heart muscle itself with oxygenated blood. When methylergonovine hits those receptors, the coronary arteries spasm, and narrow.
So the heart muscle becomes ischemic, it's starving for oxygen.
And myocardial tissue absolutely hates ischemia.
It gets cranky.
Very. It becomes highly irritable. Without adequate oxygen, the resting membrane potential of cardiac cells becomes unstable. The electrical pathways just start misfiring.
And that irritability can trigger rapid, chaotic electrical signals in the ventricles.
Exactly. Leading to ventricular tachycardia or VFib, where the heart is just quivering instead of actually pumping blood.
And if that vasospasm is severe enough and lasts long enough, the heart muscle tissue actually dies.
Which is the delayed onset myocardial infarction listed in the profile.
A literal heart attack.
Yes. And the AV block, where the electrical signal from the top of the heart fails to reach the bottom, that can occur because the nodes conducting that electricity are also being starved of blood flow.
That is wild. Okay, what about the neurological effects? The profile mentions water intoxication and seizures.
Yeah, that one throws people off.
I usually associate water intoxication with oxytocin, which has an antidiuretic effect. How does methylergonovine cause seizures?
Well, while it doesn't have the same direct antidiuretic properties as oxytocin, the severe physiological shifts can trigger a cascade.
Like what?
The seizures are often secondary to the massive hypertensive crisis. If the blood pressure spikes violently, it overcomes the brain's ability to auto-regulate its own blood flow.
Oh, wow.
So fluid is basically forced out of the capillaries and into the brain tissue, causing cerebral edema or swelling.
This is known as hypertensive encephalopathy, right?
Exactly. And that acute swelling triggers the seizure.
The clinical implications for the nerves are just immense here. You are quite literally managing a controlled cardiovascular crisis.
Which is why the clinical profile gives a highly specific mandate.
Quote, because methylergonovine is vasoconstrictive, monitor the patient's blood pressure, heart rate, and uterine response prior to and during administration.
Prior to administration is the absolutely key phrase there.
Why?
If you have a patient who is already suffering from severe hypertension, say a mother with preeclampsia or eclampsia, whose blood pressure is already dangerously high, and you give her a potent vasoconstrictor,
You are literally throwing gasoline on a fire.
you could be the immediate trigger for a hemorrhagic stroke or a seizure.
You absolutely must know the baseline vital signs. You cannot give this drug blindly no matter how much they are bleeding.
Never.
Okay, let's add another layer of complexity to this. We need to talk about drug-drug interactions because there is one highly specific metabolic interaction detailed in the profile that can lead to horrific outcomes.
This is a critical safety point.
The text highlights an interaction with cytochrome P450 isoenzymes, specifically the CYP3A4 pathway.
So to understand this, we have to look at how the liver clears drugs from the body.
Right.
The cytochrome P450 system is essentially the liver's chemical disassemble line. It's a family of enzymes that break down toxins and medications so they can be excreted.
And CYP3A4 is one of the most important enzymes on that line.
Yes, many different drugs rely on the CYP3A4 workers to break them down.
Right. Now, the clinical profile explicitly warns that the risk of ergot toxicity is potentially increased by the use of CYP3A4 inhibitors.
Let's visualize that for a second.
Okay.
If a patient is taking a drug that acts as a CYP3A4 inhibitor like certain macrolide antibiotics, such as erythromycin or azole antifungals or protease inhibitors for HIV, those drugs effectively fire the workers on the disassembly line.
The CYP3A4 enzyme is just blocked.
Completely shut down. So when you administer methylergonovine, it travels to the liver to be broken down, but the pathway is closed. The liver can't process it.
As a result, the methylergonovine just piles up in the bloodstream. The concentration keeps rising and rising.
And because the drug isn't being cleared, the alpha-adrenergic agonism becomes constant and exponentially more severe.
The vasoconstriction doesn't fade after a few hours like it's supposed to.
No, it locks in.
And the profile describes what this prolonged ergot toxicity looks like clinically, and it's grim.
Very grim.
It causes severe peripheral vasospasm with possible ischemia, potentially leading to gangrene, cyanosis, numbness of the extremities, and stroke.
Think about what's happening to the capillary beds in the fingers and toes in this scenario.
Okay.
The blood vessels clamp down so tightly that microscopic blood flow completely stops. That's the ischemia.
And the tissue turns blue and cold from lack of oxygen, which is the cyanosis.
Exactly. And if those cells are deprived of oxygen for too long, they die. The tissue literally rots while still attached to the body.
That is gangrene.
Yes. Historically, this extreme ergot toxicity was known as St. Anthony's fire.
Oh, I've heard of that.
People who consumed ergot-tainted rye bread would experience severe burning pain in their limbs as the blood flow was choked off, eventually leading to gangrene and autoamputation.
Autoamputation, the limb just falls off.
Exactly. And we are dealing with the exact same chemical mechanism here, triggered by a drug-drug interaction.
This perfectly illustrates why medication reconciliation is a life-saving nursing skill.
It's not just paperwork.
No. If you get a clinical scenario on an exam about a postpartum patient bleeding heavily, and you look at her chart and see she is currently being treated for a fungal infection with itraconazole, which is a strong CYP3A4 inhibitor, you cannot just administer the methylergonovine.
That interaction has to trigger massive flashing red alarm bells in your clinical judgment.
Gangrene. Ischemia.
Exactly. You hold the medication and immediately flag the interaction for the provider.
Because you need a completely different uterotonic agent that doesn't rely on the CYP3A4 pathway.
That's right. Now, up to this point, our entire discussion has centered on the profound physiological impact this drug has on the patient receiving it.
But the clinical profile takes a sharp, unexpected turn regarding who else is at risk.
We're shifting focus from the patient's vasculature to the danger this drug poses to the infant.
And astoundingly, the occupational hazard it presents to you, the clinician.
Let's look at the guidelines for pregnancy, lactation, and hazardous handling.
Right, the lactation guidelines are basically the bridge between maternal treatment and infant safety.
We know methylergonovine is given to mothers immediately after childbirth, but what happens if that mother wants to breastfeed?
The clinical profile issues a strict contraindication. Quote, mothers should avoid breastfeeding during treatment with methylergonovine and for at least 12 hours after administration of the last dose. Milk secreted during this period should be discarded.
There are two distinct pharmacological reasons for this. First, even though earlier data suggested canine milk concentrations were low, the profile explicitly states the drug may produce adverse effects in the breastfeeding infant.
Because you have a drug that causes profound vasoconstriction, alters serotonin pathways, and impacts dopamine receptors.
Exactly. And infants developing neurological and cardiovascular systems are incredibly sensitive.
So exposing them to even trace amounts of a potent ergot alkaloid is just an unacceptable risk.
It is. But the second reason is absolutely fascinating, and it connects directly back to that messy receptor profile we discussed earlier.
The text states the drug may also reduce the yield of breast milk. Why would a labor inducer dry up a mother's milk supply?
The profile gives us the clue. It notes that methylergonovine is less potent than bromocriptine in its ability to produce emesis, or inhibit the secretion of prolactin.
Okay, read that carefully, guys. It says it's less potent than bromocriptine at inhibiting prolactin, which means it does inhibit prolactin.
Exactly. And prolactin is the primary hormone responsible for stimulating milk production in the mammary glands.
And prolactin release is inversely controlled by dopamine, right?
Yes. When dopamine receptor activity increases, prolactin secretion is shut down.
Because methylergonovine acts as a partial agonist on central nervous system dopamine receptors, it tricks the brain into suppressing prolactin.
The drug physiologically signals the body to stop making milk.
That is wild. It's a perfect example of an unintended systemic consequence.
So the nursing management here is really clear.
Yeah.
You educate the patient on the pump and dump protocol.
For at least 12 hours after the last dose, any milk expressed must be discarded.
This protects the infant from exposure and allows the drug to completely clear the maternal system so normal prolactin levels can recover.
Okay, now we reach what I consider the most jarring part of this entire deep dive.
The hazardous drug classification.
Yes. When we think of labor and delivery, we don't naturally think of hazmat protocols.
No, we really don't. We associate hazardous handling with oncology, with toxic chemotherapy agents that disrupt cellular DNA.
But the occupational safety standards for methylergonovine are extraordinarily strict.
The clinical profile lists methylergonovine under the NOHH 2016 list as a Group 3 hazardous drug, and under the NOACE Draft 2020 list in Table 2.
It mandates that healthcare workers must observe and exercise appropriate precautions for handling, preparation, administration, and disposal.
And the specific PPE requirements are shocking. Let's break down the requirements for handling the injectable liquid formulations first.
The protocol mandates, quote, use double chemotherapy gloves and a protective gown. Prepare in a biological safety cabinet or compounding aseptic containment isolator with a closed system drug transfer device. Eye, face, and respiratory protection may be needed during preparation and administration.
Double chemotherapy gloves. A biological safety cabinet. a closed system drug transfer device.
Wait, explain what a closed system transfer device is for the listeners.
It's a specialized vial adapter that equalizes pressure. It ensures that when you push air into the vial to drop the liquid, absolutely no vapor or aerosolized droplets can escape into the room air.
Why is a labor inducer being treated with the same containment protocols as mustard gas derivatives?
Well, it all comes back to the drug's intense systemic potency. Think about everything we've established today.
Right.
A tiny 0.2 milligram dose can induce a tetanic uterine contraction or trigger a massive stroke. Now imagine you are a nurse rushing to draw up this medication. If you don't use a closed system device and a microscopic aerosolized mist of the drug escapes the vial, you might inhale it.
Oh, wow. And the lungs have a massive surface area designed for rapid absorption directly into the bloodstream.
Exactly. Or if a drop of the solution splashes onto your unprotected skin or into your eye, it is absorbed systemically.
Suddenly, you, the nurse, have a potent alpha-adrenergic agonist circulating in your blood.
You could experience the severe hypertension, the blinding headache, the palpitations, or even the coronary vasospasm yourself.
The PPE is strictly designed to prevent accidental occupational exposure to a highly reactive chemical.
Exactly.
But the cognitive dissonance here is just wild to me. You have a patient bleeding to death, a situation requiring extreme speed and urgency.
Right.
But to protect yourself, you have to intentionally slow down, don a protective gown, snap on 2 layers of chemotherapy-rated gloves, and carefully utilize a closed transfer system.
It perfectly illustrates the tension of acute clinical care. You simply cannot save the patient if you become a patient yourself.
And these strict precautions aren't just for the liquid injectables, right? The guidelines for the oral tablets are equally stringent.
Yes, the profile states, use gloves to handle. Cutting, crushing, or otherwise manipulating tablets will increase exposure and require additional protective equipment.
Let's conceptualize a real-world scenario on the floor here.
Okay.
You have a postpartum patient who needs her oral dose of methylergonovine, but she's nauseous and struggling to swallow pills. The instinct for many nurses is to grab a standard plastic pill crusher, grind the tablet into a powder, and mix it into a cup of applesauce.
Which is a catastrophic occupational error.
By crushing that tablet barehanded on the medication counter, what are you actually doing?
You are forcefully aerosolizing microscopic particles of the drug into the air directly in front of your face.
You are creating a localized, toxic dust cloud.
If you inhale that dust, or if it settles on your skin and uniforms, you are exposing yourself to the compound.
That is why manipulating the tablets fundamentally changes the hazard level and requires respiratory and eye protection.
The absolute takeaway for anyone handling this drug is ultimate respect for its potency.
You never, ever crush this medication without full protective gear, preferably under a containment hood.
You always use double chemo gloves for liquids.
If a licensing exam asks what PPE is required to draw up an IV dose of methylergonovine, the answer isn't just standard clean gloves.
No, you are looking for the chemo gloves, the gown, and the closed system device.
These aren't bureaucratic suggestions. They are the physical realities of handling a chemical that alters human vascular physiology so aggressively.
We have covered a massive amount of pharmacological ground today.
We really have. We've traced this drug from the mechanical bleeding of a flaccid uterus all the way through the CYP3A4 metabolic pathways, the stroke risks of IV pushes, and the hazmat protocols of the medication room.
Let's synthesize the absolute critical Pareto principle takeaways, the 20% of the knowledge that will give you 80% of your clinical mastery.
This is how you build a mental framework that connects the mechanism directly to the nursing action.
Point 1. The core therapeutic goal.
Methylergonovine is the chemical shrink wrap. It stops severe postpartum hemorrhage by forcing the uterine muscle into a rapid, sustained tetanic contraction.
Point 2. The administration hierarchy. Intramuscular is the preferred parenteral route because it balances rapid absorption with a safer systemic profile.
The IV route is a last resort, absolute life-saving measure only, and if you are forced to use it, you must push it slowly over no less than 60 seconds.
Because slamming it into a vein delivers a massive alpha-adrenergic shock that can induce a sudden, deadly cerebrovascular accident.
Point 3, the metabolic trap. You never mix this drug with a CYP3A4 inhibitor like a macrolide antibiotic or an enzol antifungal.
Inhibiting that liver enzyme prevents the drug from breaking down, trapping the patient in a state of prolonged ergot toxicity.
The resulting relentless vasoconstriction causes severe peripheral ischemia, potentially leading to tissue necrosis and gangrene.
Point 4. The vigilant monitoring, because the core mechanism relies on alpha-adrenergic agonism, which inherently constricts systemic blood vessels. Your primary nursing responsibility is constant cardiovascular surveillance.
You absolutely must know the baseline blood pressure before administration and monitor continuously for extreme hypertension, chest pain, and arrhythmias resulting from coronary vasospasm.
And finally, point 5, occupational and infant safety. This is a NIOSH-listed hazardous drug. You respect the chemical.
Double chemotherapy gloves and a gown for injectables, and absolutely no barehanded crushing of tablets to prevent toxic aerosolization.
And enforce the pump and dump rule. No breastfeeding for at least 12 hours after the last dose to protect the infant and allow prolactin levels to normalize.
If you can internalize those 5 points, you haven't just memorized a drug, you've mastered its clinical application.
You understand that the serotonin antagonism, the alpha-adrenergic agonism, and the liver metabolism are just as textbook terms. They are the physical mechanisms that dictate whether your patient survives and whether you stay safe while treating them.
You're building a clinical intuition that is going to serve you flawlessly out on the floor.
To wrap up our deep dive today, I want to leave you with a lingering thought that speaks directly to the reality of the nursing profession.
Let's hear it.
Consider the profound paradox of methylergonovine.
Here.
It is a vital, irreplaceable intervention. Its singular purpose is to forcefully pull a mother back from the brink of exsanguination in the terrifying, chaotic moments following childbirth.
Yeah.
Yet the exact same chemical properties that make it a miraculous lifesaver for the bleeding patient make it exceptionally hazardous to the nurse preparing it, potentially toxic to the nursing infant, and capable of inducing a deadly stroke if the plunger is pushed just a fraction too fast.
It is the ultimate double-edged sword of modern pharmacology.
It really is.
So the question you have to grapple with in your own clinical practice is this: how do you mentally and physically balance the sheer terrifying urgency of a massive postpartum hemorrhage with the meticulous, deliberate, time-consuming safety protocols of donning double chemo downs and performing a calculated 60-second FARV push?
Navigating that exact tension between speed and absolute precision is what defines a master clinician.
Well said. Thank you for joining us on this deep dive. Take this understanding, trust your preparation, and go use it to keep your patients and yourself safe. We'll see you next time.